Okay, good afternoon and welcome to today's Primary Care Resilience webinar. Before we start, there's just a couple of very quick housekeeping items to cover. Firstly, you won't be able to use your video or microphone during the webinar, but we really want to hear from you during the session. Please use the Q&A panel to introduce yourself and raise any questions for the speakers. If you have comments on the presentations, please also post these in the Q&A box. You can also upvote for a question or comment that someone else has posted by liking it. The Q&A panel shows up when you click on the icon shown on the top right-hand side of your screen. Next slide, please. Questions are moderated, so please allow a few minutes for questions or comments to appear. You enter your question or comment in the text box shown on the left. To make it more personal, please include your name with your comment or question, as otherwise it may show as anonymous. Submitted questions will show up in your My Questions tab. Lastly, please note that this session will be recorded and by taking part, you consent to this. Thank you, and I will now ask Dr. Michelle Watts to begin today's webinar.
Thanks, Lorraine, and hello everybody, and a very warm welcome on this somewhat balmy early autumn day, and welcome you to, this is number 8, would you believe, in our webinar series that we have jointly produced with our colleagues in Healthcare Improvement Scotland, Scottish Government, and with RCGP, and it's fantastic that we're really continuing on with this webinar series, and it's so welcomed by you all. So thank you for coming along today. Appreciate how busy everyone is, and it's great that you're able to take the time to come together and share learning about this important topic. Our goal for today is to network and share learning from a range of perspectives, both clinical and academic, around the subject of long COVID. We're nearly 2 years into this pandemic, and we're really recognising for some time now that there's a lot that we don't know, that we're continuing to learn. And we certainly know that our experience of long COVID began emerging really about last summer, and towards the end of the summer there was some joint guidance produced from NICE, National Institute of Clinical Excellence, and HIS and the College of General Practitioners, and that was further followed by a clinical support note at the end of last year and beginning of this year, to really try and share what knowledge that we had that was emerging to support clinicians in their discussions with people presenting with symptoms suggestive of long COVID. But I think the real kind of ethos and thread running through today is that we are still learning. There are so many people that are continuing to struggle with a very wide range of symptoms, and for many it's had a significant impact on their daily lives. And we are continuing to learn from them and from the emerging research that is continuing to give us some further information and learning around this emerging condition. So today we've got a chance to hear really where we are now, but in recognising that there's a lot much more to do. But most importantly, we're going to hear from people who've got lived experience and professionals really trying to understand how best they can help people presenting with long COVID symptoms in this developing area. So lots to get on, some fantastic speakers today that I'm really looking forward to hearing their stories. And so without further ado, I'm going to introduce you to our speakers. But before I do that, please feel free to put as much information, chat, questions, anything in the chat bar. It's our opportunity for networking here, and we really want to hear about your experience and any questions you may have. So without further ado, I'd like to welcome Maureen Nairn, our colleague from SIGN, and Dr. Nafis Ahmad, who are going to talk a little bit about their experiences. So firstly, over to you, Maureen. Thank you.
Thanks, Michelle. Thanks for the offer to take part today and that introduction. I'm Murray Nairn. I'm a Programme Manager with SIGN, which is part of Healthcare Improvement Scotland. And I'm going to say a few words about the long-term effects of COVID-19 guideline. So can I have the first slide, please? So this is the guideline we're talking about. It was first published at the end of last year. And as you can see, just a bit of context about the development process. As Michelle mentioned, it was developed in partnership with NICE and with input from the Royal College. It's a living guideline approach using a particular methodology that's been developed for very rapid development in the context of health and social care emergencies. Like all national guidelines, there was a multidisciplinary group of clinicians and people with lived experience drawn from England, Scotland and Wales, and there were Scottish clinical and non-clinical representatives on that group. Some of you may have taken part in the consultation exercise last year. And the guideline was published towards the end of the year by NICE and SIGN, two separate physical publications with the same recommendations. So at the moment, we're undergoing an update of that guideline. You may have taken part in the consultation for that, which just finished a few weeks ago, and it'll be published next month, the update. Now, the update content remains confidential, and actually I'm not working on that personally. I worked on the first version of the guideline, so I don't have all the most up-to-date details, but what I will do is talk a little bit about the public consultation version, which was up to date from about a week or so ago, and with the caveat that it may change before publication. So we skip on to the next slide, please. So it's quite easy to summarize this because the top half of the slide there, those bullet point sections are chapters of the guideline. And these are areas where we've searched the evidence, we've identified new evidence and incorporated into the guideline. But these are the sections that aren't significantly changed by that new evidence. Not surprisingly, when we first published the first version of the guideline, there wasn't a large volume of evidence. This is a condition, of course, that didn't exist in spring last year. And as Michelle said, we're still learning about it. The case definitions, of course, only were published at the time that the guideline was published, and the diagnostic codes have started to be embedded in the first part of this year. So we're still waiting for some of the evidence to filter through the research systems to be able to really empower knowledge and understanding about the guideline. So the recommendations from the original version of the guideline and all of these top sections remain roughly the same. You'll see the final version when it's published in November. What I will say briefly about what's new is there's some additional symptoms that have been identified from the excellent qualitative evidence that we've looked at from the lived experience data delivered by patient groups. We've identified that some of the symptoms are less common in children and young people. There was an additional question to look at the impact of vaccination on long COVID symptoms. And my understanding is that there's likely to be a recommendation encouraging vaccination, but the evidence on the impact directly on symptoms are still conflicting. And there's a couple of other areas of recommendations which you might say are common sense, but just as a reminder that impact on performance at work or education over a long period of time may signal an underlying condition. It may be in the context of following an acute COVID infection that there may be an opportunity to investigate that further in the context of long COVID. So let's move on to the next slide, please. Now, what I would like to draw your attention to is a tool that we have developed in SIGN in collaboration with Scottish Government and the Right Decision Service as part of the DHI team in Glasgow. And this is an app. It's available on both a desktop and mobile devices from that URL on the screen. And it contains all of the information from the guideline, accompanied by some additional implementation support materials, which are developed by a short life working group led by the Scottish Government policy colleagues involving clinicians and people with lived experience. And Nafis is going to say more about this in just a moment, so I won't steal his thunder. But what you're seeing is a screenshot of the homepage of the tool, and each of those tiles represents a chapter of the guideline. You click on any, it'll open up more information on that topic, and it incorporates both the clinical information and the implementation support information. And one of the most important and useful sections is the implementation flowchart. So if we move on to the next slide, we can see that in a little bit more detail. The flowchart here, you click on the tile, it'll open up what you see on the left-hand side. You can resize that and drag it around as convenient, and it represents a generic patient pathway of an average patient that may present. As you can see, there are sections on presentation, consultation, self-management, referral, and various types of symptoms. And what we're looking at here is the consultation box opened up on the right-hand side of the screen is more information about some pointers for care and some tests and assessments to consider. And you'll be able to work through that at your own speed. Can I have the next slide quickly, please? I just want to show you a preview of a new app that's in development alongside the professional app. The professional app's available to you right now. You can go along to that website. And we're also developing this patient-facing app, which again is a tiled approach. Each of those represents a section in the published SIGN patient booklet. You can get that on the SIGN website right now. But an additional feature is the symptom diary up at the top left, as you can see. This allows patients to record details of the range and the severity and the frequency of any symptoms they may be experiencing. It'll also generate a report which can be saved or shared with your healthcare professionals as required. And that's there because it's following a recommendation in the guideline about symptom monitoring. And it's a good example of a practical way of making the recommendations more implementable and bringing them to people's fingertips in an innovative digital model. So I'm gonna stop there, otherwise I'll go over my allocated time and hand over to Nafis, who'll say a bit more about the work we've done on the implementation support around the guideline.
That's great. Thanks very much, Murray. And it's really good to see how much of that kind of digital aspect of things has really progressed since we last worked on it. So my name is Nafis. I was a Scottish Clinical Leadership Fellow last year, working closely with the Scottish Government. And I've since returned to my day job as a urology registrar at the Queen Elizabeth in Glasgow. Next slide, please. That's great. So I've only got 5 minutes, but I'll start with some kind of cheap product placement regarding the fellowship for any of the GPSTs who are kind of interested in kind of following suit as well. So 1 year out of program fellowship is really exciting. You get to work with a lot of big national healthcare organisations. I had the privilege of working with Scottish Government, and I'm going to talk to you about some of the work that I did with that around long COVID. So if anybody's interested, you look up online, or my email address is at the end if you want to know any further about that. Next slide, please. I feel like Chris Whitty now. So first thing is, why did we look into this in terms of the implementation note? So Keith mentioned at the time, there was quite a lot kind of going on around long COVID, and I think part of our approach was a lot of discussion with primary care teams and GPs. We could see it was a growing problem, but the other thing, it was a multi-system problem, so it doesn't comfortably fit with any particular specialty in isolation. And there's a lot of interest from primary care, and our GP colleagues are in terms of what are the specialists seeing, what are the kind of nasty or surprising things that they're picking up on imaging or their follow-ups, and what do they want to see? What else can we reassure patients about within primary care? And because of this overlap of symptoms, they really don't want to miss anything more serious. Any sinister underlying pathology was completely reasonable. And our aim was really to provide that kind of support to the GPs with this kind of document, because it's such a tricky conditioning, and a lot of it does fall, unfortunately, on the GPs in primary care because of the way it sits. And this can be very difficult to manage, given all the things that GPs are unfortunately under scrutiny for at the minute. Next slide, please. So how did we go about it? So we put together a task and finish group, which isn't a term I'd really heard before, and I'm not sure I'll ever kind of hear about again, realistically. But essentially what we realized very early on, this is such a complex illness. It doesn't really involve any single body that has all the answers. So really we wanted as much kind of expertise and specialty opinion as we could get. So I had the privilege of chairing this group and working with some of the members that are actually on the call today. And it represents some allied healthcare professionals, GP, primary care, policy colleagues, psychology, third sector, and even those with lived experience as well. And they fed into their own specialist networks as well, even broadening the level of expertise and input that we could receive. So from a medical perspective, we tapped into a range of our national clinical advisors, who then again tapped into their regional national networks to ensure that we gained that kind of high level consensus approach and what we could advise the GPs, what we should be advising to do, and what we could advise and kind of reassure patients on as well. And obviously this continues to grow as we develop more and more evidence. Next slide, please. So eventually we turned out our final product, and this is where it can be found. And this, if you look up the long COVID guidelines on the SIGN website, it sits there underneath the guideline, the Scottish Government implementation note. And this is what the front of the cover looks like. I will go through some of what we might consider the highlights of the implementation that we think was most useful for primary care. Next slide. So in terms of what's in the notes, kind of quick highlight reel of what's in there. So it's not, I think one of the strengths that I thought when we produced it and when speaking to others, it's not necessarily about developing new science, because as Monica kind of alluded to, it's a very difficult thing to kind of get any strong evidence for as such. But I think it's a document that really, it's a consolidation of a lot of resources and advice that helps to navigate this condition. And a lot of this is based on existing best practice for these symptoms, but because it's such a broad spectrum illness, it helps to kind of pull everything into one place, which is kind of what we wanted to do to make it a bit more easy rather than, we appreciate how limited time can be in primary care and make things a lot easier to access. So the first thing for your attention to is we got all the coding for acute, kind of ongoing symptomatic and long COVID, essentially, all the coding in one place. And that could be useful for not just the coding for individual patients, but once that's coded for, we can help to estimate the figures and actually the wider impact on services and incidents regionally. Furthermore, we have resources in the bottom left that are actually quite useful for the patients. A lot of them have cited the help that they receive from peer support groups, which they find very useful. There's also third sector support, which has been very forthcoming in helping to support these patients as well. Murray's already demonstrated the more digital application of the flowchart, but it's in its kind of original form. And we appreciate not everybody strictly fits into these kind of criteria, but the aim is to provide that baseline approach in terms of where do I start, what are the simple things that I can begin with. And then, as I said, plug in all these kind of various resources that have been quite useful in helping to manage these patients. Next slide, please. So again, we put together quite an extensive symptom table. And with this, because of our expertise that we had on board and our advice, we pulled in lots of resources. So we've got resources for pacing, smell retraining, multiple psychological assessment tools, which are all kind of, as I say, located in one place, as well as other resources on symptoms and red flags that people can look out for when assessing these patients. Next slide, please. And we worked together with about 9 to 10 national clinical advisors who were incredibly forthcoming and really helpful and helped to put together some of this. And I've put just the respiratory and the cardiology bits in here because they tend to be the more commonly viewed areas. And I think the really useful thing about this, we kind of realize the primary care approach can't exist without that secondary care input and that specialist input. You guys will appreciate hugely the massive waiting lists that there are already trying to get people seen by specialists. So it's what can we do in the community? What structure can we provide for these patients where there's not a huge amount known about? And what can we do that might provide some reassurance while we wait for them to be seen if and when in secondary care? Next slide, please. I think I'm maybe pushing my time limit here. So I hope that document and overall the talk was very useful for you. I've put the links in here, which will hopefully be circulated wider. So you can, if you haven't seen the implementation note, you can click on the link and have a review of everything yourself. And there's also a feedback, a SurveyMonkey link, which is really useful because it's very helpful for us to understand what's useful, not just about the document, but the service as well, because that'll translate into further iterations of the document as we learn more about the illness and we learn more about what the services are available and what areas that we can essentially help you in terms of making sure that primary care are able to support these patients. Thank you very much. Back to Michelle.
That's great, Nafis. That was a gallop through what was an awful lot of hard work by many people. But I would encourage all of you, if you've not seen the implementation guidance or had a chance to look at the app, then please do. The links will be up down the side. And what we will also do is publish the slides from today. I think I'm right, Lorraine, in saying that. So if you want to have a further discussion about this, perhaps at a practice team meeting, or if you've got some learning opportunities, then please use the resource material as starters for 10. Just looking at some of the comments in the chat bar, and I think one of the challenges that many people have said that there isn't a simple test for this condition, and as we've all described, there are so many different symptoms. I'm going to come to you, Scott, in your GP surgery. How challenging or otherwise is it for you around helping to make a diagnosis of long COVID with a patient?
Yeah, that's a good question, Michelle, and nice to see everybody. Scott James, I'm a GP here from Mercer GP Scotland, and it's one of those things where it's a disease that we don't fully understand the mechanisms by which it's created, and as I think some of our speakers would allude to, it probably has different mechanisms by which it creates each of the different symptoms. So a disease without a diagnosis, no less a disease without a treatment, and that forgive me for citing some old Latin kind of premium non-knockery don't do any harm. So don't do something that will make it worse. And we've learned over the recent years, especially with our chronic fatigue patients, and how there's concern that some of the advice we might have given them historically might have been making any symptoms worse. So we don't want to do that. So I think it's really difficult, Michelle, a disease without a test and a disease without necessarily a treatment. So it's about best supportive care and definitely study what we do and taking opportunities to evidence what we do, and hopefully show some light at the end of the tunnel to help what are absolutely very real symptoms and to actually help inform and make good decisions and support our patients.
Yeah, thanks, Scott. And I think the other really important thing to recognise as well is that every person is unique and their stories are all different and their symptoms will all affect them in different ways. But GPs are part, an important part, but only a part of a wider extended multidisciplinary team. And I think long COVID is a really good example of the importance of really recognising that extended team, and particularly our AHP colleagues, physiotherapy, occupational therapy, but also recognising as well for many people, it may not just be the physical effects, but it may be the psychological effects, or indeed the financial burden around not being able to work. So I think there's a lot we've still got to learn, but one of the huge opportunities through this learning process is really thinking about how we do connect and work together as that extended multidisciplinary team. And on that note, I'm going to move us on to the second part of our discussion today, which introduces a bit more of our multidisciplinary team. And so over to you, Scott, for the next part of today's session.
Thanks very much, Michelle, and thank you for our previous speakers. That was really setting the scene about what we've tried to do nationally to articulate the challenge that's there. And I think from a GP's perspective to start, I think not only is it a disease which is needs a diagnosis, but also we can't miss other things. And I think we don't want to find out in 3 or 6 months when they see a specialist that in fact they have hypothyroidism or anemia or another disease, and that's really important. Why we have produced the guidelines and implementation that really clearly articulates that within primary care, our GP and nursing colleagues are really good at identifying other pathologies and understanding the breadth of disease and how it presents. And yes, whilst patient-led supportive care is absolutely a really key part of this, and peer support, we also don't want to miss the other diseases out there which can be mimicking it very easily. And it's with that I'm looking forward to present today. We've got Dr. Tom Farden, colleague from NHS Tayside, who has a wealth of knowledge nationally and internationally on respiratory illness, and has helped us locally guide us through some of the difficult times through COVID. We look forward to hearing from Tom, and most importantly moving on to Sinead thereafter. Sinead McCabe is a project lead occupational therapist from NHS Lanarkshire, and I really look forward to hearing from her just about the other allied health professional supports that can be there for our patients who are experiencing symptoms ongoing after COVID. And it's a pleasure to also welcome as our last speaker, Professor Alan Carson, who's a consultant neuropsychiatrist and honorary professor at the Centre for Clinical Brain Sciences at the University of Edinburgh, and he's really going to be a treat to take us through the challenges of the neuropsychiatric and neurological symptoms that he is seeing, and get that clinician's view from the coalface. And without further ado, looking forward to handing over to Tom to take us through his slides. Thank you so much.
Good afternoon, everyone. Thanks very much for inviting me on. Thank you, Scott, for the introduction. This is the obligatory picture of the V&A in Dundee, which we're all very proud of here. Let's move on. Next slide. I only have 4 minutes, so we best make most of it. So, who are we seeing who's being referred up to us for problems because of long COVID? Well, it's a different patient group to people who get acute COVID. Very clearly from the start of the pandemic last year, we noted what you all know already, that older people who are male and obese tend to get the worst bit of COVID. People from black and minority ethnic backgrounds get worse COVID. And if you've got background cardiovascular disease, diabetes, hypertension, that makes things worse as well. And being disabled, which I know is a very vague term, but any disability which you may declare on a form as would put you at higher risk of having acute COVID, and the acute COVID being worse, hospitalized or critical care. However, the group of people who are being referred to us for long COVID, yes, if you've had protracted COVID, if you've been in a high dependency area, critical care for a long time, then there's a good chance that you're being referred up. But that may well not be strictly long COVID, but maybe just protracted acute COVID, and that's difficult to tease out. The age group is probably about the same as the severe COVID group, although it extends into younger people down to about 35. Rare to see it in people under 30. In contrast to acute COVID, female sex tends to be, it predominates. People who have multi-morbidity, so people have a big long list of past medical history things already in their KISS summary. Hypertensive, obese, psychiatric conditions are seem to be overrepresented. And I mean all sorts of psychiatric conditions, including depression, anxiety, personality traits, as well as severe schizophrenia, etc. Anyone with an immunosuppressive disorder seems to be more likely to be referred, and interestingly, people with asthma, because asthma is not a massive risk factor for acute COVID or hospitalization, but it does seem to be a risk factor for long COVID. Next slide, please. This has been mentioned already by Nafisa, and the web applet thing that he showed. I've just had a look at that. Fantastic resource. Well done to the team for doing all that. It's an amazing piece of work. But what do we see? Fatigue. Almost every single person referred to me in the last 6 months, 12 months with possible long COVID is tiredness. And this is seen in 90% of people who are hospitalized with their COVID, and about 11% of people who get COVID in total. Overwhelming fatigue, tiredness, inability to do anything, taken to your bed, and exhaustion is what the people report. About half the people who are discharged from hospital will be breathless at about 10 to 12 weeks, and about 5% of all people will be breathless, whether they're hospitalized or not. And then you get into smaller fry, such as cardiovascular abnormalities, an unusual dull chest pain, which isn't related to movement, isn't related to exercise, isn't pleuritic, but can be quite disturbing. It's not severe, but it just gives a sense of doom, I suppose is the best way to say. But autonomic dysfunction is incredibly common. I think everybody I've been referred has tachycardia, everybody, and they're worried about it. And young fit people who are no longer bradycardic at rest are very worried about it, and it settles. It settles with time. It can take many, many months, but it does settle with time. And residual myocarditis is incredibly rare. One of the problems with the myocarditis issue is that we don't actually know what the background rate of myocarditis is in the population. If I did an MRI heart of 1,000 people off the street, how many of them would have signs of myocarditis? We genuinely don't know. So it's very hard to know what the increased risk is. The brain fog is very commonly reported, very hard to really put a pin in what that is and how you might define it. But more concrete things such as PTSD, depression and anxiety are much higher risk in people who've had critical illness in a critical care environment. And from our data in Tayside, you double the risk if you're a healthcare professional. So if you're a nurse, doctor, pharmacist, AHP of any sort, and you are in HDU or ICU, your risk of PTSD is double that of a member of the population. Very interesting. A lot of people can't sleep. A lot of people can't sleep because you lie in bed listening to your heart rattle along because you've got autonomic dysfunction. And also there's the numbness, weakness, dizziness sort of pattern of things, and then the weird symptom of tinnitus. Next slide, please. This has been mentioned already, but the real key thing from my point of view is not to miss important other differentials. So things which are long COVID is mimicking, and there might be a tendency to say your symptoms are long COVID and not investigate properly. So the slide that Nafis put up of the person with the metastatic lung cancer, for example. So what we've said in Tayside, and I think is working well, and actually is mimicked across the country, we're not alone here, is from a chest point of view, if you have a normal chest exam, a normal chest x-ray, your hemoglobin's okay, and you don't have inducible hypoxemia, then that's incredibly reassuring. It's very unlikely anything serious is going on. So resting SATs, a sit-stand test for a minute and measure the SATs, and if they stay stable, pretty good. If you've got inducible hypoxemia, so SATs fall during exercise, then that should trigger an urgent referral up to secondary care to look for pulmonary embolus, either acute or chronic. ILD, COPD, and all the other causes of hypoxemia that are not necessarily related to COVID. Same with chest pain. If your patient said they've got chest pain, but it's worse on exercise, climbing stairs, if you think it's ischemic heart disease, get it referred on. And if it's positional, that lying down, sitting up, then think about pericarditis. My neurology colleagues have the same strategy. If you think that someone has weird neurological symptoms, which could be MS, then that's an urgent referral, because the people can still have MS. And the patient group we're looking at that we see the most is women in their 30s, 40s, and 50s, and that is the peak presentation of MS. Peripheral neuropathies, mononeuritis, and then Guillain-Barré syndrome tends to present early in the first 6 weeks, as it does with a whole host of different viruses. So it's probably not a COVID specific thing. And of course, headache is incredibly common. It's common anyway, but it's very common post-COVID. So look out for the signs of raised intracranial pressure, which I don't need to lecture you about those today. Next slide, please. And the patterns of people that we see are exhausted, tired, lethargic people. They get quickly into a pattern of avoiding exercise because they feel so tired and it makes them so exhausted. They then gain weight, they decondition, and then they cycle round and round and round. And we have this cycle of a self-fulfilling prophecy. There's a group of tend to be younger, fitter people who notice their heart rate is very high because their Fitbit is telling them. And because they're worried about their high heart rate, they don't exercise, they get anxious about it, and their exercise intolerance worsens. And that's, again, the same sort of pattern. And then another group of people who have chest pain, anxiety, and breathlessness, they usually have a pre-existing anxiety of some sort. They may have a neurological disorder, or they have fibromyalgia or chronic fatigue, or increasingly I'm seeing people with functional neurological disorder, and they tend to clump in that group. Next page, next slide, please. So before I hand over to Sinead, what we have been doing is trying to help our primary care colleagues by pulling out the people who we think have a serious other illness that we can treat. Scott has already said there is no diagnostic test for long COVID, there's no treatment for long COVID, so it's hard for us. What we really need to do is we need to pull out those people that we can do something about. So very important things: PE early on, alternative diagnoses, don't miss lung cancer, don't miss ischemic heart disease. Liaise with your secondary care colleagues. Don't be afraid to ask for advice on these patients. The mainstay of treatment in Tayside has been our excellent AHP service, and Sinead McCabe is going to talk to us about just that. So looking forward to your talk, Sinead. Thanks very much.
Sorry. Thank you, sorry. Good afternoon. So yes, I'm Shauna McCabe. I'm the care lead for primary care and occupational therapy in Lanarkshire. And this is a fairly new initiative, and we currently have 12 occupational therapists, clinicians working across GP practices in 2 localities in Lanarkshire. And today I was just going to share our experience of developing our practice to support patients affected by COVID. Could I have the next slide, please? So the primary care staff came into post in January and February, and of course within a couple of short months we were off in a different world of COVID, and we then realised with challenges came these opportunities of how could our OT clinicians and GP practices support the GP surgeries. So we possess the skills and knowledge to support people suffering from the indirect impact of COVID and early on in the pandemic, so those experiencing issues around shielding, social isolation, deconditioning, general anxiety, and mental wellbeing problems, and just general experience of living with the pandemic. And then as the pandemic progressed, the staff utilising their expertise in both physical and mental health care have been able to deliver assessment and interventions to support the rehab and recovery of some individuals experiencing long-term physical and psychological effects of COVID. So what do we, as sort of OTs, what do we mean by our definition of long COVID? So most of our referrals do come from the GP or from practice staff. The person will probably have a history of COVID symptoms, maybe with or without a positive test, and continuing to experience some of those symptoms, and so come back to the GP, and they're really impacting on their functional ability and preventing them carrying out the roles and activities that are really important to them. Often via secondary care or with the GP support, by this time medical options for treatments and interventions were deemed to be maximised. And so as an adjunct approach, it seemed really worthwhile considering this other approach. So the holistic biopsychosocial approach of occupational therapy has a proven track record already with helping people to manage their lives while living with the impact of a medical long-term condition, which we kind of viewed COVID as at the beginning as a starting point. So from an occupational therapist perspective, with multiple symptoms, different presentations and experiences per person, but they all had one thing in common: it was really disrupting their life, their functional ability and their routines were really affected, their mood and their cognition. And I've listed here just some of the challenges and symptoms that the GP referrals would cite, or indeed that we would then uncover when we started talking to the person. We've them out for shortness of time. Have the next slide, please. Okay. So with OT being quite new in the surgeries, together with the fact that we were all grappling with the concept of long COVID, we produced this infographic on the side of your slide there to communicate to our GPs common symptoms that they might have patients describing to them that we thought occupational therapy could help with. And once the patient was referred to us, we offered them an occupational therapy assessment, adopting a really what matters to you collaborative approach. We use Cochrane, which is an OT assessment tool, which identifies areas where the person is experiencing impairment or dissatisfaction in their functional performance. And we assessed their mental health with the Web's questionnaire. And all this information was used to set goals and priorities that were really individualised intervention plans for the person. Again, listed our interventions here. I won't go through them because we're limited for time, but you can see that we do address the impact of COVID across the spectrum of physical health and mental health, and give consideration to all aspects of the person, environment, functional ability, and I think as mentioned earlier on, finances, relationships, that whole package around their home life. And like everybody else, we had to adopt a new process of working, and we developed a blended approach that had face-to-face, home visits, near me, telephone consultations, depending on clinical need. Have the next slide, please. So what was working well for us in terms of patients? So it's a team approach with the GP, obviously in practice, a really effective communication there, so that's great for us, great for the patient. It's a really responsive approach. We are in surgery, the referral processes are very easy. Patients can refer themselves. They can refer themselves back in if something changes, they've gone back to work and things are more difficult for them. It's a very holistic approach, so physical and mental health looked at together for the person, their environmental and their social needs. So that results in a lot less toing and froing between services for the patients. It's a very person-centred approach, individualised, which is very much needed with long COVID. So we're achieving good outcomes for the patients, including increased use of self-management strategies to improve activity management, thinking styles, managing stress and anxiety, and cognitive difficulties. And this is leading to a return to more healthier routines and lifestyles, gradual re-engagement and interest in social networks, improved sleep, sometimes decrease in pain, and often a return to work or with reasonable adjustments in place, and that's a big part of what we do. I've added in here just a patient story which is adapted from an audio interview with a patient that summarises the benefits that she experienced, and maybe if the slides are passed on, you'll have more time to read that. Can the next slide, please? So what's working well for the GPs, we hope that we're supporting them. This slide just shows a couple of pieces of feedback we've had from GPs. They tell us that they valued having occupational therapy via a localised primary care pathway. They value being able to offer their patients additional support model across mental and physical health issues, especially when all medical avenues have been explored, as the occupational therapist can then help the person to live alongside their condition, whatever that's going to take them in the next weeks, months, whatever. We also in turn have had access to other members of the team within the practice, so the NPs, pharmacists and a practice nurse. And we link into secondary care services, sorry, that's my timer, local resources and voluntary sector where required, and most importantly into employers and carers. And quickly, very last slide, time. Finally, what supports good patient outcomes across primary and secondary care? Just my thoughts. Referral pathways and processes that are easy to navigate, effective communication channeling, including IT, MDT approach, providing timely, efficient care with the patient at the centre, and the opportunity for shared learning and skills development across disciplines and services. Thank you, and I'm going to hand over now to Professor Alan Carson. Sorry, thank you.
Hello, good afternoon, everyone. So I'm going to talk a little bit about sort of neurological symptoms in the context of long COVID. But I hope what I'm saying might actually be relevant every bit as much to the respiratory symptomatology, cardiac symptomatology, etc. It's a very brief talk, so I'm going to simplify everything. So if you can just take a general caveat of, well, it's a little bit more complicated, but it will give you the bare bones of how we would think about the position. If I could have the first slide, please. So I want to just start off by asking, what do we know about the direct early neuropsychiatric effects of COVID-19? Because the first question we would ask, which came up at the beginning of the pandemic, is, does COVID-19 infect the brain? It's a good starting point for thinking about what comes next. Next slide, please. And this is from an early national surveillance study that I was involved in, along with a lot of others, very well led by Benedict Michael in Liverpool. It's essentially using a case report methodology for all symptoms of encephalitis, stroke, and other neurological complications. This type of methodology almost certainly underreports the degree of symptoms. But what was nonetheless striking is actually there wasn't a huge amount of neurology coming in. We thought we were going to be inundated. We expected encephalitis left, right, and centre, and it simply didn't happen. From the rehab side, we were all teed up for lots of cases of Guillain-Barré, as Tom was alluding to. Actually, Guillain-Barré's slightly rarer after COVID than other respiratory infections, for example. There's actually been a national decrease in presentations. Can I get the next slide, please? But if we want to look at something on a bit more of a large scale basis that gets away from the problems of self-report, we see a similar picture echoed. This is from the TriNet-X data set in the US. And essentially what we're looking at is rates of neurological psychiatric complications from survivors of COVID compared to people with other respiratory infections. And firstly, just the absolute rates of neurological complication are relatively low. As you might predict, the more severe the presentation is, the higher they get. But in general terms, we're looking at 1–2% of patients, not huge swathes. If we have the next slide. I think, however, the key issue from my point of view, if we're looking for hard neurological complications, doesn't matter which neurological condition you look at, this finding comes. And what you're seeing here in the solid pink line that deviates from the other three is the rate of the condition following COVID if you presented with a delirium, with an encephalopathy. The rates of almost every neurological complication goes up. Otherwise, the rates are actually relatively unremarkable. And one particular concern of ours is dementia. As many of you will know, dementia probably starts in your mid-30s if we're thinking of a typical Alzheimer presentation, but it doesn't become clinically apparent till sometime between 70 and 80. And delirium is known to expose these degenerative illnesses. The inflammatory effects of the condition just bring them forward a little bit. So there are some, nasty neurological complications, but not swathes of it. Next slide, please. So why does this affect my thinking about long COVID? Well, if we can have the first slide. Can I have the next slide? This is from an early systematic review of symptoms. And I think this, can we go back? Sorry, I think you've jumped on one. I think one of the problems is we have a mixture of reporting, and we talk of long COVID as if it's an entity. I think there probably isn't a condition long COVID. I think there's multiple conditions that occur in the context of COVID. And my slight worry is by thinking of long COVID as a thing, we actually get confused and we miss obvious pathology and obvious targets for treatment. So for example, in Tom's talk, he was talking about looking quite appropriately for raised intracranial pressure as a cause of headache, but the overwhelming majority of headache we see post-COVID is migraine. It's a decompensation of existing migraine, and migraine has well-trodden tracks for treatment and well-trodden strategies. And my worry is that if we simply think of it as long COVID, we think we don't know what to do, whereas actually we know exactly what to do for migraine. So I think that kind of clinical phenotyping is important. But this is in terms of the symptoms given. Very few of the symptoms reported have a hard, clear-cut pathophysiological cause. And when you look at the rates of things that might be considered as, they're not that high. And as Tom alluded to, and I absolutely agree with, we often don't really know what the background population rate is. So we've got to be a bit cautious about that. But the vast majority of the symptoms reported are in areas that commonly can have functional explanations. Not to say they do, but commonly do. So this is how we would start to approach thinking about it. If I could get the next slide. My group are particularly interested in detailed clinical phenotyping, and at the moment we're particularly interested in cognition because we're doing a lot of work on separating out dementia from functional cognitive disorders, of which more in a second. So we've been running studies in cognition and collaborating, speaking to others. This is from a French group looking at cognitive problems post-COVID. It's quite a nice study, it's quite small. What's interesting about it is this is looking at predictors of who will make cognitive complaints. The first thing is that actually the severity seems to be the reverse. In other words, those with ICU admissions who are more likely to actually have brain damage, if you like, are actually much less likely to make cognitive complaints. And a standard measure that I would use for acquired brain injury, a digit symbol substitution task in that bottom row, has zero predictive measure. The only thing that seems to predict the likelihood of making a cognitive complaint is rates of anxiety and depression, which might be suggesting to us that psychological processing issues and attentional dysregulation are quite important in what people think of as brain fog, rather than hardline damage to the underlying brain structure. Could I have the next slide, please? So I'm going to deviate sideways into an area many of you won't be familiar with perhaps, but I think is quite important. And this is functional cognitive disorders. About half the presentations to memory clinics will be something in the spectrum of functional cognitive disorders, with the other half being sort of neurodegenerative. Again, crude simplification. You can get the next slide. And what we're interested in terms of definition is this idea of clinical evidence of internal inconsistency. And really, if it was weakness, or if it's tremor, or any other neurological symptom presenting after COVID, the same idea exists. This is what we do in our clinic. So we look for those who've got neurological hard signs, or those who've got evidence in internal inconsistency in their signs. If I can get the next slide. So to give you an example of this in cognition, internal inconsistency with this patient presenting, it's forgetfulness. For example, I forgot the name of the doctor who I saw in clinic. Oh, it was doctor, and then named them. Had to check his name. Frustrating. I'll watch a film and think, who's that actor? For instance, I was watching a film called Pimpernel Smith and I couldn't remember the actor in it. Leslie Howard, of course. I remember things 40, 50 years ago, even 4 or 5 years ago, but sometimes I struggle finding words. The other day I went out to see a pal, took my jacket off and I thought I'd lost my wallet, but I just put it on the other side. Now, this is a patient who's really struggling with their memory, really concerned about it, but actually are demonstrating completely intact episodic memory. What they've got is a problem with attentional regulation and being able to access memories when they wish. And this is an example of an internal inconsistency. And this is telling us that this is predominantly a functional problem. And we can do the same for motor activity, same principles, but I think quite an important distinction. Quick tidbit for general practice, if you just ask the patient, what is wrong with you today? And they can talk for over 60 seconds fluently about what's wrong, the chances of them having any hard cognitive disorder are so close to zero. It really is really quite predictive. Can we move on to next slide? So the sort of things we would be looking at are patients attending alone, patients more concerned, being able to take turns in conversation. You're giving detailed accounts and elaboration. You're demonstrating intact cognition. If you can give examples of memory failure, you're actually showing that you had intact episodic memory for that event. That lack of repetition that you get. Actually remembering what happened from 1 minute of the consultation to the next. And I know we're all taught in medicine don't ask compound questions, but actually it's sometimes quite helpful to ask a compound question and see if both bits can be answered. So trying to make these distinctions we think is very helpful. Could I get the next slide? And we would put this together and we would really say, as I say, that there isn't such a thing as long COVID. There are lots of really very real and very disabling problems after COVID infection, but it's not helpful to think of them as an entity. So we can have post-encephalitic impairment. It's as rare as hen's teeth. I'll be lucky if I've seen a case. Stroke does occur, and you'll get post-stroke vascular cases. Delirium exposing dementia is a bit more common, and that's probably the biggest differential. And then we have delirium, ICU stays leading to PTSD and the consequent psychological cognitive problems of PTSD. Persistent ill health, persistent respiratory symptoms, chronic lung disease will just knock you off a little cognitively. But we also have a large chunk of people with chronic fatigue syndromes and functional neurological disorders, and not all of them have even had COVID. You know, the first wave, we see a lot of people, when you explore the symptoms, they don't really sound like they were actually COVID infections as a trigger. They're all people who need treatment, but the treatments are very different. And actually, for everything on that block, we have well-established evidence-based treatments for every part of it. And I think by saying to things, they're long COVID, it stops us thinking and doing what we already know works for all these subsections of it. So I suppose I'm suggesting let's roll back a little bit. Can I have my final slide, please? So just to echo what a few people have said, people are still people, the same risks apply. Not everything's COVID. Make sure we just do the obvious. Rates of neuropsychiatric disorder go up if you presented with an encephalopathy. If you didn't have an encephalopathy, probably don't go up much in terms of neurological disease. About a quarter of patients to a third report persistent cognitive problems. Our experience so far is the vast majority are functional disorders, but with vascular disease and neurodegeneration distant seconds. We've got a CSO-funded clinic in clinical neurology at the Royal Infirmary. We'll see any patients with long COVID-related cognitive symptoms from Lothian, but we're also happy nationally if their COVID's been serologically confirmed to have them referred and to see them for clinical and research assessment. I'll stop there. Thank you.
Thanks so much there, Alan. That was most interesting, and I think as the speakers are articulating, I think we ourselves are grappling with how do we capture this and articulate this that's both in a useful and unified way for clinicians, but also that doesn't belittle the importance of working through normal process through differentials and treatments which have established evidence base, but also are going to be helpful and supportive to the patient. You're right, just labeling it and letting them go off and do things themselves might well either miss other pathology or miss evidence-based treatments. Just looking in the chat for the last minute or two, some really nice posts there, both from notable Twitter colleague Amy Small, who's a GP colleague in Edinburgh, as I recall. She's been posting things in the chat, which I'm sure people are noting, and has some lived experiences. I think some of our speakers do today of COVID. This is an emotive subject for all of us, and I think it's consumed all of our lives, and all we want to do is try and navigate ourselves to what's the best way for our patients. But I think, and what Alan's saying, I don't know maybe what Tom or Alan's reflections of this is, and I think Tom, particularly locally in Tayside, we've grappled with how do you do service design for this, and potentially Sinead, you have similar things, but it's trying, how do you wisely invest the money that the Scottish Government have released rightfully released for the management of this, but also don't invest money in things that you are not going to necessarily help. And it's about how do we wisely utilise these extra resources locally, and also not negate people who have other long-term fatigue issues through dementia or through another thing who might well be doing that. Thomas or Sinead, do you have any final comments in the closing minutes or two about that service design and Long COVID Fund? Because I personally have grappled with it myself. I don't know exactly what to recommend locally when I get asked about it.
I'm quite happy to come in here. I never said in my slide at the beginning of my slide, and I should have said we are not a COVID service. We are an occupational therapy service of work in general practice, so we see people across a whole range of conditions. We obviously picked up with COVID patients as and when they presented. Within Lanarkshire, there is move afoot to have the share of the Scottish Government money, and they are in the midst of setting up a rehab service for COVID, and wait and see how that shapes up. So we're, as I say, it presented itself in GP. We were there in GP, so we saw it in amongst all the other things that we see. Occupational therapy is not particularly condition focused. It's more about what the person can't do. Obviously, having some understanding of what's going on with people is really important, so you do no harm. But we would envisage continuing in that way. Taking on board what everything's been said today has been really helpful. Thank you.
Yeah, and I think that's true, Sinead, and I think that's the danger, that if we invest in one service and then we don't need it, then what do you do with it as the demand goes down? Tom, have you any final closing remarks on that in the last minute or so there?
Yes, so our service was built as a multidisciplinary service with highly specialised physio, OT, psychology input, primary care clinician, and then secondary care from me. Specifically for the response to COVID, and I said in one of the comments that was initially patients accessible by telephone, and we've quickly realised that jumps the filter, the important filter of, are we missing something else? Are these migraines, as Alan pointed out, are they having PEs? Is this ischemic heart disease? Is this something else that would have presented anyway, regardless of COVID? So we're moving our system so it's integrated with primary care first, and then that's that filter in there. I think the important thing is working with your HSCPs, making sure that it's multidisciplinary, making sure that there's rapid pathways to when you do pick up that people are not tired, they actually are having chest pain when they walk upstairs, and then they're exhausted, so they need to see a cardiologist, that they actually have daytime somnolence and they need to be investigated for obstructive sleep apnea, because these things are subtly different. As one of the posters pointed out in the chat, that tiredness isn't the same as fatigue is not the same as somnolence is not the same as exhaustion. So, but our AHP team here have been fantastic at teasing those things apart. They're very good at that, and so I've been involved, and tried to streamline those pathways to make sure that we pick up the people where it is urgent to see them. Data in the BMJ from just a couple of weeks ago suggested that in the baseline population, about 3.4% of people who've never had COVID fulfill some or all of the criteria of having long COVID. So, as Alan said, things happen anyway. So we need to be a little bit cautious about what is long COVID. It's a constellation of symptoms that are sometimes unexplainable, and as Sinead has said, we're looking after people, not diagnoses. So it's supporting people through a difficult time using a multidisciplinary approach, which I think across the patch we're doing very well, and we should recognise that we're doing really well here in a tough spot.
Yeah, well articulated, Tom. And I think today's breadth of speakers highlights that. And mention of cardiology there, Dr. David Murdoch was going to be joining us today, a cardiologist, and unfortunately wasn't able to do so, so we've had to do some jiggling around, but and that was unforeseen, and but I think would have contributed wisely to this breadth of everybody trying their best and across a multidisciplinary team. Can I just get next slide, please, just to highlight a few closing things for anybody on the call. We have an evaluation survey which will be linked in the chat, and we will follow up with an email with resources which we will issue as well. And the date of the next webinar, we will be aiming for spring 2022, into the start, and we'll communicate through the usual channels as to what the contents of that might be. We're really looking forward to what that might bring in the new year. And next slide, I think HIS are just going to plug, I think, for the launch of the serial prescribing toolkit for any primary care people on. They've just launched a serial prescribing toolkit to, I think, I'll call it a preamble to, if you call it electronic prescribing. It's certainly on the way to that, having worked through what paper-free prescribing is going to look like. You need to get your patients onto serial prescriptions to start that. So if ever there was a time to reduce your workload and practices and stop those signing of scripts over the lunchtime, if you want to increase serial prescribing, the toolkit has been launched to support that. So I've been asked by his colleagues to launch to plug this. So there we go, and happy to do so. Everyone, thank you so much today for joining us. Thank you in particular to all of our speakers. They've been absolutely excellent, and I hope I've given a really good flavour of what's been going on with regards to it and all the hard work that's been doing, and all the esteemed, internationally acclaimed colleagues that we have in Scotland trying to progress this as best we can in a very logical way. Thank you to everyone who's attended, and I hope you really enjoyed it. Thank you.
Bye everyone, thank you.